Yeah, we are live now, ma'am. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for 55th episode of AMOGS, Emergency Obstetrics Committee with Pune, Ahmednagar and Baramati societies. So, it's my privilege to introduce the convener of today's webinar, Dr. Madan sir. Sir is the consultant OBGYN and aesthetic gynecologist, chairperson of AMOGS Sexual Medicine Committee, past secretary and president of ACLUJ OBGYN Society. I welcome you, sir.
Saito, it's okay.
Yes. It's my privilege to introduce Dr. Pratibha Baldava, ma'am. Ma'am is the director of Baldava's Fertility Point Test Tube Baby Center, treasurer of Solapur OBGYN Society, and past secretary and also executive member of Solapur. I welcome you, ma'am, and I hand the session to conveners.
Okay.
Yes, you can take it.
Let us start the webinar with prayer song.
Ma'am, shall I start?
Yes, madam.
Yes. Good evening, everyone, all the respected faculties and delegates who have joined today's particular webinar. This is the 55th episode of series started by ma'am on behalf of AMOGS Emergency Obstetrics Committee. Today's session is organized by this committee along with Pune, Ahmednagar and Baramati societies. I welcome all the office bearers of the particular societies and respected office bearers of AMOGS and the chief guest, Dr. Sunita ma'am, and our own Dr. Kiran sir, and the guest of honor, Dr. Parag Biniwale sir, and Professor Muralidhar Pai sir. First, I would like to introduce Dr. Sneha ma'am, who is the main brainchild behind this and continuously doing hard work for this committee. I welcome ma'am. Ma'am was the past chairperson of Breast Committee of FOXY, governing council member of ICOG, and currently she is the chairperson for Emergency Obstetrics Committee of AMOGS, founder president of Vidarbh ISOPAB, past president of Yavatmal OBGY and also IMA Yavatmal, and executive member of AMOGS since 5 to 6 years.
Thank you, madam. That should be okay.
Yeah, ma'am is a great academician and working too hard, and I welcome ma'am and hand over to you for further proceedings. Thank you.
Thank you, madam. Thank you. A very good evening to all. My respect and regards to all the seniors present here. A very good evening to and welcome to all the president and secretaries of the societies of Pune, Ahmednagar, Ahilyanagar, and of course Baramati societies. At the outset, I would like to welcome the entire team of AMOGS office bearers, President Dr. Kiran Kurtakoti, Secretary Dr. Bipin Pandit, and Treasurer Dr. Madhuri Mendare, and of course the immediate past President Dr. Rajendra Singh Pardesi. I would like to also welcome the chief guest for today's program, Madam Sunita Tandurkar, the President of FOXY, who is right now busy in the FIGO meeting and she will not be able to join, though we have Dr. Kiran Kurtakoti as chief guest, and guest of honor, Dr. Muralidhar Pai sir. All of you know sir as a revered teacher and academician, and of course my dear friend Dr. Parag Biniwale, whom you know as the chairperson of ICOG as well as national coordinator of AMOGS. I welcome all the speakers, Dr. Uma Wankhede, our dear friend, and of course my batchmate and very dear friend, Dr. Girija Wagh, all the esteemed faculties, panelists, and chairperson. I welcome all of you, of course, the attendees. So, as Emergency Obstetric Committee, we have been, planning programs in such a way that they are practically helpful to all the practicing obstetricians. We are trying to reduce the not only maternal, but also the perinatal morbidity and mortality. So with this, I would just request our chief guest for today's program, Dr. Kiran Kurtakoti, to guide us, to bless us. So Kiran Kurtakoti, a very dear friend whom we know since last 25, 30 years almost now, and he's the president of AMOGS,
It's okay.
ex-chairperson
Sneha, it's
committee.
okay. Sneha,
Yes,
Sneha,
yes,
it's
yes,
okay. Thank you.
yes.
Thank you.
Thank you,
Well,
Kiran.
first of
Please,
all,
go ahead.
today's chief guest, Dr. Sunita Tanwadkar, today's guest of honor, my dear friend Parag and Dr. Murlidhar Pai, and of course, conveners, Dr. Pratibha and Madan, and presidents, Dr. Renuka, Manish Matswe, and president of Baramati Society, Dr. Jha. So, finally, Sneha, you are back in Maharashtra, huh? Because I have been attending all your webinars. I think this is the 55th webinar. You have taken me probably to Chhattisgarh, Punjab, Tamil Nadu, to Kasoga and everywhere, and finally you are back to my own society, that is Pune Gynec Society, and of course with Ahilyanagar, the newly coined society of Ahmednagar, so that is Ahmednagar Society, and Baramati Society. So thank you, Sneha, for that wonderful journey all across India. So, are you there, Sneha?
Of course, I'm listening to you very carefully. Thank you.
Okay. So, thank you for this wonderful journey all over India. And today, you really have galaxy of speakers. We have teachers of teachers. First of all, Dr. Mahendra, who is going to bless us with her expert opinion when you are conducting the panel. And of course, the guest of honor, the revered, one of the most revered teachers, I would say, Dr. Murlidhar Pai. So, thank you for that. And our close associates, Dr. Girija and Uma, whom we have seen for the past 30 years or so, की probably ज्यांच्या जिभेवर सरस्वती नाचते असं म्हणायला हरकत नाही. So such revered teachers and respected academicians you have. So thank you so much for this academic extravaganza, and my of course best wishes to you, to your forthcoming elections, and of course best wishes to entire AMOGS, and all the delegates who have logged in for this program. Thank you so much, and please get on with the program. And also on behalf of AMOGS, I would urge all of you, that Dr. Murlidhar Pai, last year we have started the Maharashtra College of Obstetricians and Gynecologists. So I would urge all the members of AMOGS to be members of MCOG. The forms are available with your respective presidents and secretaries. The first convocation will be held on, the first convocation was held in Chandrapur. The next convocation will be on 16th at Amravati, and then at Solapur. Dr. Pratibha, you are there at Solapur. So I would urge a lot of people from Solapur to be members of the MCOG. So with that small ado, thank you so much, and my best wishes to this program. Thank you.
Thank you so much, Kiran, for that guidance as well as best wishes. Thank you. I would request Dr. Murlidhar Pai sir, or Dr. Parag Beniwale, I would have first. So definitely, I don't think Parag, you really need any introduction. This is our own society. So of course, Chairperson ICOG and National Coordinator of AMOGS, we proudly have you with us. We would be very happy to listen to your precious words, Parag.
Thank you, Sneha. Good evening. I bring greetings from ICOG, and it's indeed a pleasure to address the gathering on behalf of ICOG and AMOX. Sneha, I've been attending your programs in different states. So, one thing which all of us have learned in COVID is to connect, and you have used this committee to the fullest potential because you have connected to consultants all across the country, and there has been some excellent exchange of knowledge in all these 55 programs that you're doing. It's not very easy to sit in front of your desktop and be attentive and of course prepare all these lectures. So my best wishes to you, best wishes for your forthcoming election, and of course today's program. I'm happy to have two excellent teachers from Pune who
Yes.
are incidentally the next two presidents of the Pune OBGYN Society, Dr. Uma Wankhede and Dr. Girija Wagh. So I'm looking forward to some excellent learning session from them. And of course, the panel which you're going to conduct will definitely add value to the program. So thank you once again for inviting me. And pleasure to share the dais with Dr. Muralidhar Pai, who was my governing council member a little earlier. Thank you, Murali, for joining.
Yeah.
Thank you, Parag. Thank you so much. And with this, we move ahead to have blessings, of course, guidance from Dr. Muralidhar Pai, whom we are fortunate to have you as guest of honor today. I'm sure all of us are blessed with and enriched with knowledge from you. You have 37 years of academics experience, 25 awards, 15 international fellowships, 207 publications, 3 textbooks, 850 guest lectures, and of course, you are the, I think, Vice Chancellor and Dean. So we congratulate you for, your very well-deserved position and the honor. Over to you, sir, for your precious word.
Thank you, Dr. Sneha. It feels like coming home every time when I accept either a lecture or to be a guest of honor. Actually, I cannot be guest of honor. I'm the host, actually. AMOGS has become my home society after Karnataka. And I'm very happy Dr. Kiran announced that you have started Maharashtra College of Obstetrics and Gynecology. I was the pioneer in starting the Karnataka State College of Obstetrics and Gynecology. Then, of course, I handed it over now after coming to Sikkim. It's a great thing to be associated with the all academic webinars or conferences or sessions. I love because it gives me an opportunity to meet people, erudite people like the panel today she has put up. Dr. Sneha has been working tirelessly for last 3 years. Whether she won the post or she didn't win the post, this shows her commitment to academics, and this shows her, resilience, in life. I sincerely wish, Sneha, that this time you win thumbs down, and you deserve it. That's why, and not because you are my friend or you are conducting webinars. I think I would like to see you as Vice President of Foxy this year for sure. And I'm sure you will continue to conduct such academic programs even after winning. And today's topics are very, very important. And the speakers are very, very erudite, as Parag said. And it's always a pleasure to participate. Thank you so much. I wish all the best.
Thank you, sir. Thank you so much for, all your insights into the subject as well as our activities. And we are very thankful to you for your gracious presence as well as your precious words. Thank you. With the blessings of God Almighty and of course the respected seniors, we would like to go ahead with the academic session, and I would like to hand over the session to Dr. Madan and Dr. Pratibha. Thank you so much. Over to you, Dr. Madan. Thank you, everybody, for gracing the program.
Thank you so much, madam.
Thank you, Sneha ma'am, and thank you all the guest of honors for having you today here. Thank you. Over to you, Pratibha, for the session number 1.
Okay. Very good evening, one and all. Today we are going to start session 1, which is a very important and an emergency topic of blood prolapse. For this, I would like to invite as chairpersons Dr. Ashwini Kare ma'am, who is a chief IVF consultant and a director of Asha Kiran Hospital and Asha IVF Center. She has many positions and contributions to her credit. She has been a joint secretary of Foxy, convener of the embryology workshop for annual MSR 2025, and organizing secretary for ISAR Aspire Conference 2024. She was elected MCM Embryology ISAR 2022-24. She has been an awardee for Foxy Shanta Yadav Award, awardee for Foxy's and IAC Traveling Fellowship. She was a zonal coordinator for AMOGS in 2018 and 20. She has also been a treasurer, a managing committee member, and a past treasurer of MSR. And she has been a peer reviewer of Jogi, which is a journal of Foxy for 2016 till the present time. I invite you, Dr. Ashwini Kare, madam. Ashwini, madam, have you joined? I don't see her.
She is also contesting for the managing committee member for MSR. So we wish her all the best for her elections.
We have Dr.
Yeah, she must be there.
Dr. Amit Kade, has he joined? Dr. Amit Kard is our second chairperson for today. He was the immediate past secretary of AOGS, Organizing Secretary Presidential Conference of Shirdi, Joint Secretary IMA Ahmednagar, and MTP Committee Ahmednagar Municipal Corporation. He's a member of the same. So I invite Dr. Amit Karde. Our speaker for today is none other than Dr. Uma Wankhede, madam. She is a professor and head of the department of GMC Baramati. She has been an examiner for MBBS, CPS, DGO, MS, and DNB. She has got a Fogarty Fellowship from Johns Hopkins University, USA, and she has published more than 50 scientific papers and is a famous speaker in local, state, national, and international conferences. And she is also going to be the future president of POGS. I welcome you, Uma, madam.
Thank you so much.
Ma'am, I have your slides, which is there in the presentation. You want me to start sharing them?
Please, please.
Yes, ma'am.
Thank you very much, Dr. Sneha, Dr. Madan, Dr. Pratibha, for giving me this opportunity.
Yes, I'll just start the slideshow.
Yeah, please.
Can you see my screen? No, not. Okay, I'll just start share. Okay. Is it seen now?
Yes.
Okay, okay. Whenever you say next, ma'am, I'll just click forward and then we can go ahead.
Yeah, thank you. Actually, the whole lecture in one word would have been if that there was a cord prolapse through a cesarean section, but then that is not the case. We'll have to discuss it a bit. So next slide.
Okay, just a minute. Okay.
It's an important cause of fresh stillbirth, and it's an unpredictable emergency, and timely delivery is the hallmark of good obstetric management. But in India, still we have lots of patients who are not registered or who have to travel long way with cord prolapse to reach hospital, and that causes resultant fetal death. Next.
So now the cursor. Just a minute, ma'am. I'll just. Okay, it's going on the click. Okay. I think they are back. Okay, ma'am. Now it's going. Yeah.
Yeah. So it is defined as descent of the cord into the lower uterine segment, where it may lie below the presenting part or beside the presenting part without intact fetal membranes. And when membranes are intact, it's called cord presentation. Next. There is a term called occult cord prolapse or compound cord prolapse, where cord is adjacent to presenting part. We cannot palpate it, and it causes unexplained fetal distress. I told you before, phonic or cord presentation is cord palpated with membranes below presenting part, and cord prolapse is cord is in vagina with ruptured membranes below presenting part. Next year. The incidence of cord prolapse is unknown, occult cord prolapse, but it is 0.5% in cephalic and frank breach, 5% in complete breach, 15% in footling, and 20% in transversal. So you can see that in malpresentation, there's a lot of cord prolapse. Next. The common etiology that we all teach is incomplete fitting of the presenting part in the meatheral pelvis at the time of rupture, and so the cord can slip through. So what are the causes? Most important is malpresentation, but nowadays it's becoming lesser and lesser because there is a widespread use of elective cesarean section in malpresentation. Fetal anomaly is also important cause. I remember as a resident, as sonographies were not so common, so we used to run for doing caesars and babies would come out anencephaly, etc. But this also has become less because of the widespread use of sonography. Same with low birth weight. Many times there will be excess liquor and a poor fitting presenting part, which could cause cord collapse. And same case in twins because of excess space for the cord to slip through. Next. Maternal factors is, of course, rupture of membranes, spontaneous and even artificial, preterm labor because of excess liquor, and pelvic tumors, which may cause the space or prevent the presenting part to fit into the pelvis. Next, placental factors is polyhydramnios and minor degrees of placenta previa, where the space is there for the cord. Cord abnormalities are low content of water and jelly may increase the cord turgidity, and long cords which have the propensity to have prolapse. Now, the iatrogenic cause is very important is when we do ARM, occurs shortly after rupture of membranes. One study estimates that 57% occur within 5 minutes of rupture, while 67% occur within 1 hour. So always we have to be careful that before we do ARM, the head should be, the presenting part should be fitting well, and we must check after we do the rupture. In case of external cephalic version, internal podalic version, placement of balloon catheters for cervical tightening, applying fetal scalp electrode, all these manipulations could cause cord collapse. What are the consequences? First is cord compression, so the vessels are blocked by the presenting part, and another is vasospasm, either because we handle it or the temperature changes when the cord comes in the vagina, and all this causes birth asphyxia and either fetal death or HIE. So whenever we do ARM and the fetal heart changes, we must suspect it and quickly do the PV. So it is confirmed by PV by either feeling the cord below the presenting part or within membranes. There's a pulsating structure in the vagina, or it can be visible outside the vagina. This is typically accompanied by bradycardia or severe variable decelerations, though fetal heart changes are only present in 2/3. Next, the presence of a limb pulses cord. We should not think necessarily babies died. We must auscultate and do the sonography to check for the fetal cardiac activity. What is the differential diagnosis? Fetal malpresentation like a limb of the fetus, and possible other cause of fetal sudden bradycardia include maternal hypertension, uterine rupture, vasa previa, and abruption placenta. So, cord decompression should be attempted as soon as the diagnosis is suspected till the baby comes out, and the interval to punic decompression will be more important to outcomes than interval to delivery. Most urgent delivery is required in case of bradycardia because cord arterial pH declines significantly with the bradycardia to delivery interval, and this may indicate an irreversible pathology such as vasospasm or persistent cord compression. However, cord arterial pH does not correlate with deceleration to delivery interval, indicating that intermittent cord compression causing deceleration is reversible and less risky. So we should be more worried about bradycardia than decelerations. Management in occult cord collapse, we all know we give left lateral, oxygen to the mother, IV fluids, stop oxytocin, continuous fetal heart monitoring, amnio infusion if you don't have facilities for Caesar, and immediately do cesarean section. And the increased use of antepartum obstetric ultrasound, especially with Doppler, has assisted in making the diagnosis of a presenting cord and preparing for cesarean delivery before overt or occult collapse. So every patient with malpresentation, twins, prematurity should undergo ultrasound before labor to exclude the possibility of a cord presentation. If there is a overt prolapse, speed is essence, and perinatal outcome is directly determined by the diagnosis delivery interval. The three important components are prevent or relieve the cord compression and the vasospasm, check for the fetal heart, and quickly deliver. So to prevent the cord compression and vasospasm, we can do manual elevation. We all do this. The assistant with a gloved finger will lift the presenting part so that the cord pressure will be relieved. With gentle handling, the cord should be reposed back in vagina and pack the vagina with saline soap balls till the Caesar is done. There is a Vago technique where the bladder can be filled with 500 to 1000 ml of normal saline, and this will lift the presenting part. This also inhibits uterine contractions. Tocolytics also can be tried like subcutaneous terbutaline, and if fetal decelerations persist and delivery is not imminent, the administration of a tocolytic can be attempted to relieve pressure on the vessels, umbilical vessels, and to improve the placental perfusion till Caesar is done. You can try different maternal positions to uncomfortable like genupectoral, Sims lateral, and Trendelenburg to lift the pressure of the cord. Fetal assessment, check that it's alive, because if it's dead, then we can allow normal delivery. Rule out any abnormalities, check for the sonography report, and check the gestational age for the viability. And most important is prompt delivery. If cervix is fully dilated, vaginal delivery can be done. If it is anticipated, the delivery will occur in 20 minutes. So this may you may use a forceps vacuum or breech extraction. But if cervix is not fully dilated, emergency scissors should be done within 30 minutes. The fan which is in the vagina should be there even during painting and during induction. Empty the bladder before induction, which you have filled before. Check the fetal heart before induction and have a good anesthetist who will do a quick spinal. Competent neonatologist should be present, as many times babies may be born flat with low upguard. And if cord prolapse occurs outside the hospital, patient should be given head low in the ambulance and head should be elevated either by hand or filled bladder. Prevention is use of antenatal USG in women with high risk factors. Women with transverse oblique or unstable lie should be offered elective cesarean section. Women with PPROM should be admitted and regularly monitored. Bradycardia or variable distortions, we must immediately do PV. We must always think of cord collapse and avoid ARM if presenting part is unengaged and mobile. And if it's absolutely required, then next. If it is necessary, it should be done after fixing head with a needle instead of a cocker and keep OT ready for if required cesarean section. Post-natal debriefing of all such women should be done if they have been rushed long distances, if they have the finger has been in the vagina for a long time, if they've been rushed for emergency seizure, and if they had a stillborn or a very severely depressed baby. Cord prolapse is a life-threatening condition for the baby that occurs in labor. Rapid identification and immediate management may help to save the life of the neonate. Thanks a lot for your valuable time. Thank you. Thank you, Dr. Sneha, for this opportunity.
Thank you. In fact, thank you so much, Uma, for sparing your precious time. And of course, you have enriched us with knowledge. We're very happy to have you as a speaker. Thank you.
Thanks.
Yeah. So do we have the chairperson, Dr. Ashwini is also busy with the madam. That is what the message is. I just want to know whether Dr. Amit is present here. Do we have any comments from the chairperson? Or we can move ahead with the second talk. We have Dr. Girija Wagh, our dear friend, as a second speaker present here. We can move ahead. Thank you so much, Uma, once again. Thank you.
Thank you
so much. That was in fact a very short and sweet presentation on cord prolapse. It gave us the idea of how to manage such an emergency and how to keep the baby viable. Keeping the cord inside was very by saying that we keep the bladder full or keep the hand in place is an important take-home message. Now we go ahead with session 2. The topic for session 2 is placenta percreta on table, how to manage. The chairpersons for this session are Dr. Shubhangi Wagmode, who has completed her MBBS from BMMC Sholapur and MD from GMC Miraj. She is a life member of Foxy, life member of Baramati OBGYN Society, life member of IMA, via president of IMA Baramati. She has worked as a lecturer at GMC Miraj, Akola and Baramati. Currently, she is working as an associate professor at GMC Baramati and doing private practice too. She has worked as a secretary of Baramati OBGYN Society in 2016 and 17. I welcome you, Shubhangi, madam. The next chairperson for today is Dr. Neelam Bagal. She is a secretary of Ahmednagar OBGYN Society. Can I have her CV, please? Okay, I welcome both the chairpersons and I hand over the mic to them to welcome the speaker for today, who is none other than Dr. Girija Wagh. Are the chairpersons there? Okay, I'll introduce Dr. Girija Wagh, madam. She needs actually no introduction. She's a professor and head of department of BVTTU MC Pune. She is a director of Primrose Wellness and Care Hospital. She consults at Bharati Hospital, Primrose Wellness and Care at Cloudline, SB Road, and Swargate 2. Her professional highlights are that she's a veteran gynecologist and a medical consultant with expertise in patient management, research, and medical education since the last 34 years. She has been
it's enough. Let's start with the session. Okay. Thank you so much.
Yes. Welcome. Welcome, Dr. Girija.
Yeah. Thank you. Thank you, Sneha, for this opportunity. Thing is that, I had a little sort of a personal crash on my presentation somehow. But I hope I have been able to deal with, and my message will be there definitely to, sort of give us the correct answer. So it's saying continue to share. So should I say continue to
Yes,
share?
Yes, ma'am.
Okay. So thank you, Sneha, and wish you all the best. I've always been seeing how hard you are working, and you have always taken so much knowledge to our own AMOGS, and I'm really very proud of you. And
thank
keep going, because we all have to finally keep on encouraging each other, understanding things, and especially negotiating our patient care properly. And
yes.
today, when we are going to speak in the next few minutes about placenta accreta, I have not gotten the typical statistics which are necessary, because all of us are very well aware of it. But what happens when there is an intra-operative surprise, and what should be our surgical strategy to deal with it? And this is a very, very common thing, because there are quite a few colleagues who have shared this with me always, that there have been such problems when there was a sudden diagnosis, and then you may not be absolutely well equipped to deal with it. Now, when we look at this spectrum, we all know that it refers to a range of conditions where placenta is abnormally attached or invades the uterine wall. And the intrauterine surprises often involve unexpected difficulties during delivery, especially excessive bleeding. For some reason, the placenta doesn't come out. Or if you are doing a surgery, C-section, again, it can be an extremely scary experience. And therefore, the surgical strategies range from leaving the placenta in situ to cesarean hysterectomy, with conservative approaches like uterine reconstruction gaining traction nowadays. Now, this is the spectrum where we are absolutely well versed with, where we know the invasive cells start on the uterine wall, then it's relative to the invasive depth affecting on the myometrial level, and then subsequently invading the serosal level. I must tell you that there are a lot of genetic studies also going behind it, which is talking about why such kind of predisposition would be there. And then there is a lot of, conflict going on. Can we prevent this in our own patients in the subsequent? If we have the time at the end, we'll discuss this. Now, why do we need to understand PAS? Because non-separation of the placenta leads to massive hemorrhage, associated complications, and we all know that pregnancy is always on a balance of coagulation failure because of excessive tissue fragments that are there as a load on the woman's body. And correction and treatment of hemorrhage often requires massive transfusion, ICU care, interventional radiology procedures, and a hysterectomy. And this also contributes to an overall increase in morbidity as well as mortality. So our focus today is on intraoperative surprise. And this is a surprise which I'm going to share with you today. And this is, I'm really grateful to my colleague, Dr. Sumit Devre from Malegaon, who had shared with this. Recently, this has happened. So I thought, let me bring it as a first case. So this is a P2L2 query A1. Previous two cesarean sections, on and off bleeding she used to have, and she was brought in shock and was already started on noradrenaline by the primary person who had sent him to them. She had a history, medicated termination of pregnancy done outside. And this was without doing any sonography, because since she had irregular bleeding, it was believed, she thought that she is 6 weeks pregnant. And now when she came to Dr. Sumit's place, he did a POCUS, that is point of care ultrasound, and it found that there was a single live intrauterine pregnancy of 21 weeks with 160 fetal heart, and there was an intraperitoneal clot of 300 liters, no PV bleeding, and the shock was disproportionate to the picture that he was seeing. So they decided to make a working diagnosis, and that is where we have to give them brownie points, that probably with the two C-sections, this may be MAP, with a serosal perforation, intraperitoneal bleed, and therefore they planned an emergency laparotomy. And with all the things and all the scenes in place, of course, they did this, and you can see the small baby, and just look at the amount of bleeding that is happening outside. And they found that it was actually a placenta perpetua. Hysterectomy was done. Massive transfusion protocol was initiated. Patient required a ventilator support, obstetric hysterectomy, bilateral internal iliac ligation, and fortunately, everything went well. Now, we know that there is a concept of S1, S2, and many times your only internal iliac ligation may not salvage you. But they were quite lucky, probably because the pregnancy was of a smaller duration. And at this point in time, this has happened to him in about 10 days back. The patient has been absolutely well and has gone home. So, these things can happen. So, one of the lessons learned is that whenever you're trying to do any kind of a termination of pregnancy in a woman with previous 2 sections or a scarred uterus, be absolutely sure what are you doing for her. Because we all know that cesarean sections are associated and increasing numbers of C-sections increase the possibility of increased accreta, increta, and percreta. We are a little lucky because accreta is a commoner one and not the percreta one, but all the same, we have to be on guard. There is another such surprise on table which I have experienced. And this was a patient who had come to us with recurrent pregnancy losses. And this time she had taken her pregnancy to 8 weeks of gestation. And she told me that, my previous doctor has said that you undergo termination because there are a lot of synecdoche inside. I said, you're already 34. Let's try and get this pregnancy ahead. So we took this pregnancy till 33 weeks of gestation. And then after that, the baby started showing severe fetal growth restriction, Doppler changes, and we decided to do a planned cesarean section on her. And when I took out the baby, I found that generally, when you're taking the baby, you're waiting for the placenta to separate. Placenta wasn't separating. And I put my hands inside the uterine cavity and I just couldn't see any placenta anywhere. So you could see that this is a OH specimen and you can see there's a complete thinning out of the posterior placenta. She had a completely global placenta because of her recurrent miscarriages in the past. She also had SLE, thinned out myometrium, and within 4 minutes, like her husband was sitting next to her, I said, we are going to take out her uterus, otherwise she'll bleed torrentially, and she did bleed, and we did an obstetric hysterectomy and saved her. And you can see that this is the specimen where you really cannot make out where is the myometrium and where is the placenta. And then we sent it for histopathology. The report came as placenta accreta. We had to initiate the massive transfusion protocol. So one of the most important strategies here is you have to have a massive transfusion protocol in place and follow the same principle as we will do for a roadside accident. It has to be 1:1:1 ratios, and that's the simplest thing to remember. And at least try to get her hemoglobin to 8 to 9 gram percent, and platelets should at least be a lack of them. So all these things are essential whenever we are looking at this surprise. When I'm going to deal with this patient, am I going to go inside now? Have I landed myself in soup? Or yet nothing is being done and I have diagnosed it. So we are going to discuss this as well. Now, sometimes if you are lucky enough and if you have access, I'm sorry the media is not playing, but this is something that I want to tell you, that we can do uterine artery embolization. The moment you have this surprise, even on table, you need not open the patient's uterus at all. If you have taken the uterine abdominal incision, you are seeing those typical signs suggestive of placenta. It is a surprise. Don't cut it if you are not prepared. First, be prepared. Or what you can do is you can do a uterine artery embolization and then go ahead. Now, the surprises can be of very many kinds. Sometimes you have removed the baby and now the patient is bleeding and you are scared because it is all invading the bladder wall and you don't want her to bleed. You don't want to get in because you're not prepared. There is no additional surgical help there. And in that situation now, what do we do? So we can keep the placenta inside. Do not fiddle with it. Just, you can see here that what has been done is they have applied a tourniquet and above the level of the placenta edge to help compress the uterine vessels. So go on the uterine vessels, compress it, and try to keep the placenta inside. And later on, maybe you can consider doing a delayed or hysterectomy, or which is also called as a deferred hysterectomy. We have to always never downregard aortic compression in these situations. And you should also be ready that there can be an S2 segment bleeding where you will not be able to stop it only by internal iliac ligation. And therefore, it's important that you keep a provision of pelvic packs always ready in your obstetric unit. Sometimes you may have to consider, as was done in Sumit's case, as you know, intentional cystotomy. And where, while you're doing it, just be careful that you're protecting the trigone or there can be an ureteric injury. So an intentional cystotomy with posterior bladder wall adherent to area of percreta, you can see if you suspect bladder involvement, perform this to identify the extent of the placental penetration, and that can help us in controlling the bleeding now that you have gone inside. So you can see here, many times we can also consider, and there's a huge Japanese study over this, wherein you can do a deferred hysterectomy. Just close everything, keep the placenta inside, stabilize the patient, and then keep a plan of reopening her after maybe 7 to 14 days, where the placenta would have now got shrunk, and you would be then better prepared, and then you will be able to do a better dissection. Now, looking at these signs on the table are very, very important. You can see that this looks like a prominent ischemic portion of the uterus. Why is it so? When the fetal presentation is behind, why is this bulge? Such questions you must definitely ask, and you can consider doing a sonography on the table itself. And this is what can happen, as you can see, the specimen of placenta accreta. Now, we all are aware of care bundle, and these are the 6 points where consultant obstetrician planned and directly supervising delivery, and anesthetist is there supervising the, not the assistants, but the person himself or herself. Blood and blood products are available. Multidisciplinary involvement in preoperative planning is essential. Discussion and consent including all kinds of possible interventions which may be necessary for that patient, and then local availability of a level 2 critical care bed. Wonderful care bundles. But these are those 6 points which probably would be accessible to those tertiary care centers which are already well equipped with it. What about those who will have a sudden surprise? So whenever we are doing these sonographies for a placental bed, and especially in women who have endometriosis operated, adenomyosis operated, a scarred uterus or previous section, it's very important that we look at those telltale signs of an abnormal placental implantation, which can be a retroplacental zone, because many times we are only concentrating on the baby. Don't. Sometimes you may have an accreta, even if it's not a low-lying placenta. Especially the posterior placentas are notorious. It's not always the ones which are sitting on the scar. And that's the reason why we have to look for these abnormal placental lacunae. We have to look for any kind of exophytic invasions, and then thinning of disruptions, as we can see in our patients. So there are a lot of such things, and especially if you put in a color Doppler, you are much able to look at the placenta as well categorically. And 3D color Doppler, you can see what a wonderful picture here is. And this is exactly that Bhayanak picture, as you can see on the table. Now, if you aren't prepared, if you are not knowing this, please do not take any incision here. If at all it's mandatory, you can take an incision in the fundic region, remove the baby, and don't do anything with the placenta. Or else, put everything inside, close and go. Now, this one is a delivered patient, and you can see where the incision has been taken way away from the placental site. So this is something that has to be practiced so that we don't get into problems. Be on guard in the first trimester when you're seeing that the gestational sac is in the lower uterine segment. In the second trimester ultrasound, anechoical placental areas and an irregular placental myometrial interface. And very thin, less than 5 mm anterior myometrial thickness is something that we have to consider in the third trimester. And then again, I'm sorry, this is not running, but this was an hysterectomy for a placenta accreta, which I was demonstrating, wherein you are just keeping that accreta pace at point, and you're taking a typical classical C-section and quickly putting the vascular sutures on the side, delivering the baby, and then doing an obstetric hysterectomy. So on a global scale, cases of placenta accreta spectrum are often just identified during cesarean delivery because they are missed during the antenatal care screening. And routine operating teams not trained in managing the placenta accreta spectrum face such difficult surgical situations and must make decisions that they may define the clinical outcomes. So the general recommendations for intraoperative management of the spectrum, as I was talking right now, no studies have described the clinical entity of the unexpected placenta accreta spectrum cases in resource-poor settings. And cesarean sections are increasing. We all know they are increasing even in the LMICs, and these are leading to this particular problem. And unlike in high-income countries, we have more challenges. So existing PS management guidelines are designed for specialized center, and many PS cases would be there as surprises on table because they did not have an access to an antenatal care or a diagnosis, and therefore we all require to now capture our experiences and try to find out what went. Now, there are a few things which I have taken into here from one of my orations which I had given on PPH, and therefore you will find the innovation 14 and all. Please ignore those numbers. But what I'm trying to tell you is, in your obstetric center, always in a group we can consider, have an access to activated factor 7, that is Novo 7. It's available, and it may do a lot of trick in salvaging patients like this. Very important innovation is you should have aortic, iliac, and uterine clamps. Our Piles clamp is extremely famous. There are Riboa clamps and there's so many others. And these are going to really help you. Sometimes you can even consider resuscitative endovascular balloon occlusion of the aorta or cell salvage systems. And they can help you in saving lives. And you must have good retractors and good clamps so that you have an access to the larger vessels and you can quickly go there and save the patient's life, because placenta creta is going to be a surprise. And we have to know that there's something called as a concept of a permissive hypotension in hemorrhagic shock, which has certain advantages because you are keeping the blood pressure low. So the chances of loss of blood and those valuable blood products is minimized. And this is something can be practiced when we are doing such kind of cases. Another very important thing is this helps especially in high-risk cases like placenta creta, where significant blood loss is going to be anticipated. So you can do an obligatory hypotension and then do the surgery. Never ever, and I'm very sad to know this, that many of us are not having these NASG garments, and I'm very proud to tell you that I have it in my Bharati Vidyapeeth University Medical School, and wherever I operate obstetric patients, I have ensured that NASG garments are there, because even while you're going to take the patient from the labor room to the delivery room, if you apply this NASG garment, it's going to help you in protecting the central hypotension and damage that's going to happen, and the woman's vitals will be perfused. And this is something that we have to follow and always be armed with to deal with. I have done a placenta creta case where I remember we had put the NASG garment on the table. I had planned the entire case. I said, the moment I open up and she starts bleeding, we are quickly going to, and I've done a drill. And we actually saved that patient. So we have to remember these small things wherein you would be able to salvage. Now, last one very wonderful article I came across, and I want all of you to go and read this article. And this was published by Rosie Aryananda, and this was management of unexpected placenta creta spectrum cases in a resource-poor settings. And what did she find? That previously undiagnosed placenta accreta spectrum in resource-poor hospitals is associated with a high-risk maternal mortality. Open-close abdominal surgery or leaving the placenta in situ seems to be the best choices for unexpected placenta accreta spectrum management. And the telemedicine with a placenta accreta spectrum center may improve prognosis. And what is this telemedicine? So all the obstetricians should be aware of understanding that this can happen in their lives, and they should know which intervention should be avoided. So a bluish appearance of the uterine wall with newly formed vessels is an important intraoperative sign of an advanced grading of PS, which could be confirmed during telehealth. Intraoperative diagnosis of PS could play a crucial role in improving maternal outcomes. So the lessons learned are: don't jump. A person who is wise, as says Charlie Munger, no wise pilot, no matter how great his talent and experience, fails to ever use his checklist. Thank you so much for giving me this wonderful opportunity. And I request all of you to please ensure that all of you do the voting and vote for Sneha. She has to become the Vice President of Foxy this time.
Yeah, we ensure that, madam.
Thank you.
Thank you so much, Girisha, madam. That was really insightful. And with those pictures, you have really shown how much is the severity of the blood loss and how dangerous it could be when we take an incision on that those huge vessels which are in the lower segment. You have told us how to avoid the placenta and give an incision on the upper fundal area, which is a good take. Thank you so much, Girija madam.
Thank you.
The chairpersons, are they there? Yeah.
Thank you so much, Girija. That was very, very, it was very enthusiastic, very encouraging, I would say, because this is a diagnosis, people are afraid of, actually afraid of. I would use that word, because that too, when you see it on table, then too half the courage is gone already, and the way you have asked them to tackle it, guided them so systematically. I think hats off to you, and I'm sure it has helped everybody. Thank you so much, Girija. Thank you for your time as well. Thank you.
Thank you so much.
And
Now we
special
move
thanks for
ahead.
my best wishes. Thank you.
Ma'am, chairperson is there, ma'am.
Yes, myself, Dr. Neelam Bagal. Yes, ma'am.
Yes,
As
welcome,
usual,
Dr.
your talk
Neelam,
is very
and keep going.
informative. Yes. Ma'am, I was a little bit busy in emergency LACS, so I joined late, but I listened all the lecture of Girija ma'am. Thank you, ma'am, for your very good guidance and the methods what were explained for the emergency on table unexplained placenta accreta. Thank you so much.
Okay, now we move ahead to the session 3, which is a panel discussion for which the moderator is none other than Dr. Sneha Bhuya madam. And I also invite the experts for this panel discussion, who is a very senior doctor, Dr. Savita Mindale madam and Dr. Jyotsna Daule madam. Sneha madam, please.
Yeah, please introduce madam.
Yeah. Sneha madam needs no introduction. Sneha madam has finished her MBBS and MD from BJMC Medical College, and she is a managing director of Sukkarta Hospital Maternity Surgical Home, and she has 32 years of experience in this field. She's been she's also electing for the vice president post, as we all know, and we give her all the best wishes for the same. She has given multiple talks and has publications, 25 article chapters in the national books, and peer reviewer of Jogi. She has received multiple awards and accolades which are to her credit, amongst which the most important is the National Faculty HPV Masters Transfer Award. And she has received the National Individual Award by Foxy. She has received the Dr. Anandibai Joshi Award by Government of Maharashtra 2025. She has received
Thank
the
you, Pratima. Thank you so much. Thank you. Please introduce the panelists. Thank you so much.
Okay, can I have their slides, please?
Expert slide, ma.
Yeah, can you move ahead the slides? Okay, our panelists for today, can you hear me?
Yes, ma'am, we can hear you, ma'am.
Okay, am I audible? Okay. Our experts for today is Dr. Jyotsna Dhaule, madam. She has finished her MBBS DGO from Pune, and she is director of Dhaule Hospital and Matrutva Test Baby Center at Ahmednagar. She is practicing in Ahmednagar since the last 26 years. She is a member of Ahmednagar OBGYN Society and started a center in 2004 to 2005 at Ahmednagar. She's delivered the first test baby of Ahmednagar, and she has delivered first ICSI baby, first frozen embryo baby of Ahmednagar district. She was a past president of AMOGS 2016 SHD, chairperson of AMOGS, and we welcome you so much, Daule madam.
Madam, everyone knows it's okay.
Yes, thank you so much, madam, for joining in. Our panelists for today are Dr. Tushar Gadade, sir.
Welcome, Dr. Jyotsna Davle, and welcome all the panelists.
Yes, good evening, everyone.
Good evening.
Our panelist for today is Dr. Tushar Gadade, who is the Secretary of Baramati OBGYN Society. I welcome you, Dr. Tushar. Our another panelist is Dr. Renuka Pathak, and she's a consultant obstetrics gynecologist and an endoscopist at Swasthya Hospital Medical Research Center for the last 17 years. She has special interest in high-risk obstetrics. She has finished a diploma in hospital administration, and she is a medical superintendent at Swasthya Hospital. Welcome, Dr. Renuka Pathak, madam. Another panelist for today is Dr. Deepa Bhandare, madam, who is from Baramati OBGYN Society. I welcome you, Dr. Deepa. Dr. Preeti Dungarwal, she has served as a lecturer in BJ, Pune, and as a gynecologist in various institutions, and owns her hospital at Ahilyanagar since the last 32 years. She's worked in scientific committee, in society conferences, and as a clinical activity organizer. I welcome you, Dr. Preeti Dungarwal. Our another panelist is Dr. Lakshmikant Behle, who has finished his MBBS MS from BJMC Pune, Director of Lotus Specialty Hospital Pune. He has been a past treasurer, joint secretary, and his special interest is recurrent pregnancy loss and high-risk obstetrics. I welcome you, Dr. Lakshmikant. Another panelist for today is Dr. Sriraj Katakdond. He has finished his MBBS, MS, and FMAS. He is an assistant professor at DY Patil Medical College, Pune, and he is a life member of POGS and AAFP. His special interest is high-risk obstetrics, infertility, hysteroscopy. He has published many papers in national and international journals. I welcome you, Dr. Katakdond. Okay, so we have all the panelists on board. Sneha, madam, now you can take flight. Please start moderating the panel.
Thank you so much, Dr. Pratibha, for taking this program to a very high level. Thank you. I would say introducing me and all the panelists. Of course, I'm very happy to have my dear friend Dr. Josna as the expert. Madam Savita Mahendra is, of course, in US at present, so it's not a good time for her. She could not join. So I would just go ahead and welcome Dr. Tushar Gadade, Dr. Preeti Dungarwal, Dr. Renuka Pathak, Dr. Lakshmikant Behle, Dr. Deepa Bhandare, and Dr. Shreyas Katakdan for the further panel discussion. So, friends, I would just start by saying that all of you know that the childbirth is actually a sentinel event in the woman's life. I'm sure you know that it is intensely emotional as well as intensely physical. Maybe the previous generations used to say that it is like having a second birth or rebirth in the woman's life. This is the situation, and it's not as easy as 1, 2, 3 pushes and the baby is out and everything is happy. So our aim of labor and delivery is, of course, delivering a healthy baby from a healthy mother, and it should be a emotionally fulfilling experience. So maybe when we were the PG students, or even today when we are the senior most obstetricians, the dilemma still exists. And of course, the action is taken depending upon whether we are the proponent of the masterly inactivity and watchful expectancy, or we are the protagonist of the active labor, that is what response follower. So we just start with this first case, Dr. Tushar Gadade. Do we have Dr. Tushar? Do we have Dr. Tushar? No? I think I can see Dr. Tushar Gadade. Hi. Dr. Tushar, please unmute yourself. I can see him. Dr. Tushar, can you please unmute yourself? Sahiti, can you please unmute? Hello, Sahiti. I can see. Can all of you see him?
Yes.
I don't know whether
we can see him. Yeah.
Yeah. So, but then why he is not able to hear us? Is it? Can somebody call Dr. Pratibha? Can you just call him and ask him to unmute?
Yes, ma'am. I'll call Dr.
So I can see he's paying attention also. So
I will just ask him to unmute, madam. I will just call him up. I'll call him.
Hello, madam.
Hello.
Okay.
We are very happy to have you, Dr. Tushar. We have the first case for you, 28-year-old, Gravida 4 with 3 abortions, previous abortions. Now she's having 39 weeks of pregnancy and she's in labor. So she delivers a full-term baby girl. Placenta is not expelled for around 45 minutes of birth. So what is your clinical diagnosis for this case and how would you proceed for the further management?
Okay. Thank you, madam, for giving me this opportunity. This is a case of retained placenta.
Yes,
When
perfect.
when the placenta is not delivered after the 30 minutes
Yes.
of the delivery of baby, then we called as a retained placenta.
Correct.
In such a cases, we observe the patient if there is a bleeding present or not. If the bleeding is there, then placenta may be impacted placenta. It is or a retained placenta. For managing the retained placenta, we generally take the help of the anesthetist and call our help of our trained staff. We have to explain the condition to the patient and relative. We have to assure the patients, keep the blood ready and everything is ready. That is anesthetist and our senior obstetrician if you are doing the new practice. And
very important point you have brought up, that if she's having bleeding, that means the placenta is already separated.
Separated, yes.
It may be just a retained placenta. Maybe it may have been separated completely or incompletely. But if she has bleeding, that means some part of the placenta is already separated. If it is an adherent placenta, that too completely adherent, there is usually no bleeding. But suppose you consider this as a routine case and you find that, it is just a case of retained placenta. So what steps you take practically before actually going for manual removal of placenta?
Hello?
Yes, tell me. Sometimes what happens immediately when you see that the placenta is not coming out, not separated, not bleeding, maybe even after 30-45 minutes, what steps do you take before taking her to operation theatre?
Okay. I will first reassure the patient and relative take the consent of there. That is, we are going to do the procedure in the operation theater with that may needs anesthesia. The patient may get profusely bleeding during the procedure.
Right.
Then we also inform them that we have to do hysterectomy to save the life of patient also.
Okay.
And keep the blood reserve. And
okay, that is good. Anything else anybody want, Renuka? Before going for MRP, do you want to do some things, some simple maneuvers you feel that, because of all this, it may just separate and come out?
Drain bladder.
Yes, perfect. Somebody said
bladder, we have to drain the bladder first because that is the common problem we face, that if bladder is full, uterus become peritoneal, placenta get impacted.
Perfect.
Separate and impacted placenta is there in the uterus. That is the simple way we have to drain the bladder first.
Right. Even, full bladder may lead to uterine atony and just separation of the placenta is not happening. So you just catheterize the bladder, start the oxytocin, and, you find in no time the placenta separates and delivers. That is the most fortunate outcome, I would say. But sometimes you catheterize the bladder, you put on oxytocin. In spite of that, you try control cord traction. So it is not coming. Now in this scenario, what will you do? We can take this forward. I think Renuka can discuss this.
In such a case, then we have to start considering whether it is an accreta, whether there are other causes of what are the causes for retained placenta. So if it's a simple retained placenta, if we call an anesthetist and then we do control cord traction, it would be easy. But at such a time when if we should now be ready that if it is an accreta or if it is an percreta, then what we are going to do. And so before we call the anesthetist, we should have blood ready now and inform the relatives. First have a talk with the relatives that this could be a situation like that.
So would you like to do an ultrasound even at this point of time?
Yes, I would. Yes, we could add an ultrasound examination.
Rather than struggling with the placenta, making her bleed torrentially, then taking her up for laparotomy and the further procedure, it's better that even at this stage, when you find that even with, all these basic manuals, you are not able to separate the placenta, it's better that you go ahead with ultrasonography, confirm that yes, there is a plane of cleavage. So if you
Yes.
have a confirmed plane of cleavage, definitely you can go ahead with MRP with the help of anesthetist now standing with you. So definitely that is going to succeed. But if you have a diagnosis of PAS, maybe acrita, increta, percrita, then definitely you will not even touch that patient at that point of
We can
time.
leave it.
Correct? Right. Now, now that the discussion further is already done here, that was for percrita. But suppose you find that this patient who is already delivered vaginally, now you feel that there is retained placenta, and the diagnosis is confirmed that it is adherent placenta. So, what would you like to do for this patient? When it is diagnosed acrita or increta, how would you go ahead with the management?
We have to take the consent for the laparotomy of the patients, and we have to proceed with the laparotomy. And if in an offsetting hysterectomy, sometimes we have to perform.
Yeah, but then what will you tell the patient? Whether it will be elective, at least at this point of time, it will be an informed consent for obstetric hysterectomy, or it will be still just opening the patient. What will be the consent? The consent will be
consent
for
including if we are confirmed that it is the adherent placenta or it is placenta increta or percrita, then we have to take the consent of the hysterectomy, obstetric hysterectomy also, ma'am.
Right. So definitely, see, if you have a multipara, definitely who is already having this should go ahead with the obstetric hysterectomy. Only in few cases where you find that there is no bleeding at present and the patient and relatives are absolutely not willing for hysterectomy. So with all, explained situations and with all preparation ready, maybe you can go ahead with the conservative management of the the surgical procedure, the conservative surgical procedure. How many are for keeping the placenta inside and retaining it like that? Can we have the show of hands or say that yes? Dr. Sriraj, what do you feel? Should we leave this placenta inside?
Yes, ma'am. If we want to conserve the uterus, in that case we can do the placenta and just wait and watch. If it get detached of its own, then it's okay. Otherwise, we can use of this methotrexate. Sometimes it can be helpful.
Okay, so see, if I tell you that maybe around 3 to 3.5 decades ago, when we were PG students, we have done many such cases that you leave behind the placenta, let it get necrosed, and let it separate on its own. The majority of the cases, happily they used to get separated and expelled out. But there were few cases where the patients landed up into septicemia, septicemic shock, secondary hemorrhage, and even obstetric hysterectomy could not save the patient. Okay, that time. So that is the reason evidence has come saying that you are not supposed to keep the placenta inside and close the uterus, and you're not supposed to. There is absolutely no for methotrexate, but because methotrexate acts only on the rapidly growing cells. Okay, methotrexate doesn't act on the necrosing cells or tissue. So evidence is strictly against keeping the placenta in situ and giving methotrexate. So we have to follow the guidelines. Either you have to take the decision for obstetric hysterectomy. If no, then we have to go for what is called as conservative surgical procedure, where you have the triple P procedure. Okay, triple P procedure. So what is that triple P procedure? Anybody from the panelist?
There is a partial resection of this we can try.
Yes, there are three. Yes, what is it? Yes, Dr. Preeti?
Partial only part where the placenta is this we can try resecting that. If it is we are going for the surgical process, conservative surgery.
Yeah. So you're partly right. Yes, because suppose if you have patchy adherence of the placenta, then only you can go ahead with this, what is called as triple P, where the first P is mapping of placenta. So placental mapping is the first P. Second is pelvic devascularization. So stepwise pelvic devascularization, go for internal ilia, go for uterines, and then even the upper and lower parts of the uterines. And third is patchy resection. So triple P procedure. So these are the ones when you actually have the adherent placenta. Now somebody tell me just important steps of MRP, then we go ahead. I think Renuka will be the best person to talk about this. Dr. Deepa, yeah, can we have it from Dr. Tushar? Important steps of MRP.
Yes, madam. We do the MRP with due consent, of course, with the help of general anesthesia.
Okay.
We give the general anesthesia to the patients and hold the cord. If cord is not torn out, hold the cord and just give some traction. And
Okay.
with the left hand and put your hand in the vagina and pass through vagina up
Hold the
towards
cord
the
with right
uterus.
hand, right? Hold the
Yes.
cord with right hand and give counter traction with the left
Yes.
hand. Maybe
Yes.
just stabilize the fundus.
Yes.
Now, when you go along the cord, you try and reach the surface of the
Surface
placenta.
of the placenta.
Go
Yes.
towards the edge where the placenta and the myometrium interface. Then you
Yes,
try
ma'am.
to separate it.
Separate the
Okay?
placenta
Create a
from the
plane.
uterus.
Yes.
Yes.
Separate it all around and then you turn the placenta as if you are
Yes.
turning a bit of books. That is how it is
Yes.
described.
Yes.
With the same hand, you come out. So
Come
that
out.
is how you deliver. Then you give, of course, the oxytocin.
And we have to observe. We have to observe the placenta. That we have to. For the missing any cotyledon or membranes behind, so
Right.
the uterine surface of the placenta we have to observe properly
Right.
after delivering the placenta.
So maternal as well as fetal surface
Yes.
should be observed because maternal surface that for missing cotyledons and membranes, as you said, but fetal surface also sometimes you have vessel running, indicating that there may be a subcensurate lobe of.
Subcensurate. Yes.
Okay.
Yes,
So
ma'am. Yes, ma'am.
very well discussed, all of you. We go ahead with the second case now, Dr. Renuka, for you. We have this 36-year, second gravida, 36 weeks pregnancy. She comes to you with previous normal delivery and now she is having strong labor pains. Vitals are normal, fetal heart is good, cervix is fully dilated, fully effaced, and now she has breech presentation station +1. Pelvis you feel is adequate. How do you manage this patient?
Now this patient is actually has had a normal delivery. So this is the second delivery. She's fully dilated. So now I will make every readiness for a normal delivery. So an assisted vaginal breech delivery, that would be my plan. So first I will assess the baby's weight per abdomen.
Will you have a backup plan for cesarean section?
But for this patient directly now that she's fully dilated, station is +1.
Okay.
And so I will first assess her abdominally whether the baby's weight, because at that time patient is in active labor. So
okay,
at that
so what is Zattucini score? How will you find that whether she can deliver vaginally, whether it is favorable or no? What all things you assess for this?
First is that the weight of the baby. So that is one thing. Here the station, the parity, the history of previous breech delivery. If she's had the first delivery was normal.
That is normal, not breech delivery.
So it was a normal delivery. So it was not a breech delivery, but there is a history of a normal delivery.
Yeah. But sometimes what happens
that is also going to be favorable for us.
Yes, but sometimes what happens that you feel that she will deliver and the breech doesn't come out, or maybe the breech comes out, the rest of the body gets strapped. So, or maybe even the after coming head gets strapped, then you have to face the, aftermaths. So, whether you would give them a choice, whether you would give them a choice for cesarean section or vaginal delivery, what would you prefer?
Now, because this delivery, give them a choice that there is a possibility that the aftercoming head may get stuck, and that is why there is one choice that you can do an emergency cesarean section at this point.
Yes.
Or otherwise, an assisted breech delivery is always the
Yeah.
present.
Okay. So by
But there
the
is
time
a
you
minor risk of aftercoming head that
Yes.
we'll have to explain to the relatives
Okay.
before we do the assisted vaginal breech delivery.
Okay. So how would you deliver the breech vaginally? What is called as assisted breech delivery?
For assisted breech delivery, the first thing that you would take the patient in a lithotomy position, give a lithotomy position for the patient, then
Right.
take a big episiotomy will be given,
Yeah.
and you allow the breech to deliver. So here you don't give any traction, nothing till the baby, the breech has to climb the perineum, and it will distend it, and then you'll give the episiotomy and allow
Right.
the baby's buttocks to deliver. If the legs are flexed, at that time you can deliver each leg as it comes. If the legs are extended, you still allow the baby to deliver. At such a point, you can add pitocin so that the contractions are a little strong, and you can ask the patient to bear down. So during contractions, so that will help the baby to come out. Then once you see
the legs
shoulder,
are extended. Renuka,
then
suppose the legs are extended and they are not coming down, then
the next contraction, you'll ask the patient first to bear down.
Yeah. Okay.
When the patient bears down with contractions, that will push the baby outside. And then you can remove the legs after the
so what is
umbilicus
Pinard's
come out.
maneuver? I
Then we
would
can
ask
make
you.
For Pinard's maneuver, then you will have to press the
Can you all
your
hear
hand
me?
in
Any problem with my voice? Okay. So can anyone talk about Pinard's maneuver? Pinard's maneuver. Suppose the legs are extended, you tap the popliteal fossa so that the leg gets flexed, and you
popliteal fossa so that the leg gets flexed and comes up.
Yeah. Similarly
Then,
on the opposite side.
On the opposite side.
Okay. Now
then when you see
your
the
baby has
scapula,
come down up to scapula.
Yes. Then you can deliver each hand. You can put your fingers above the clavicle and then flex the arm and get it out. So that is when the arms are flexed, it is easier. But you put your fingers above the shoulders, and then you can flex the arms and remove both one arm at a time.
Okay.
Then then you leave the baby hanging till you see the nape of the neck. And then by Burns Marshall technique, we take the baby along the long arch, and then we allow the baby's head to deliver. So usually with this Burns Marshall technique, many babies deliver. In case it is not delivering, then we can use the Mauritius smelly white, where in which you put two fingers on of the left hand on the shoulder as of the baby, with the middle finger will be on the occiput so that it will flex the head, and the other fingers, the right hand, you will put in the mouth of the baby so that it will allow us to flex the head and deliver the baby. So Mauritius smelly white.
Yes. And suppose if everything fails, then you have your forceps for the aftercoming head, right? Yeah, Piper's forceps. Dr. Priti, you want to add anything?
Actually, assisted breech delivery is letting the baby deliver till the umbilicus that way. And then we just wait and watch, allow the baby to hang by its own weight till the nape of the neck is seen. That is the best method. Take to the edge of the labor table, allow the baby to hang by its own weight. And then we try the Burns Marshall. So, and at the same time, the assistant can give a gentle suprapubic pressure so that the flexion of the head is maintained. And stand by the side, lift, hold the ankles, and just by one big arc of the shoulder, we just move this. So and that gentle suprapubic flexion is maintained, and the head, it comes out. So that is in fact the assisted. We don't even, I think, try to take out the hands or anything. If the hands, they don't come out on their own, then only we try to just by a simple method, we can try to
Yes, yes. So that is what actually
that
Dr.
is the
Renuka has
assisted
discussed,
breech.
the assisted
Otherwise, it is
breech
breech
delivery.
extraction which is there.
No. Assisted breech delivery is the one where the baby hangs up
I
to.
think in assisted breech, you can assist the
out.
hand.
Yes, you need
Only
some
if it is not
assistance.
coming just by gentle, we don't go up to the clavicle or something like that. We just hook it and try to remove it. That's what I feel it is.
No.
Hook it. What I meant to say was you hook the shoulder by putting your hand above, and then only you can take the flex the baby's arm and come out. How can you otherwise?
Yeah,
it
so
doesn't come out on its own.
Let me clarify. Actually, assisted breech deliveries let the baby come up to whatever it's coming on its own. But whenever it requires assistance, like the limbs, lower limbs, when it is extended, you need to tap and just pull out. Similarly for the hand, sometimes you have a knuckle hand. So that also, these are the special situations where you need assistance. And the last assistance is after, of course, for the delivery of the after coming head, where you have those 3 maneuvers. So I think that all of them have been discussed well. So we can move ahead. I just wanted to know beforehand, suppose now this was an emergency, but if at all you know that your patient has got breech presentation at around 36 weeks, can we just decide or plan whether she should go for planned vaginal breech delivery or planned cesarean section, and how should you decide it?
We can go for external cephalic version if they are willing after 35 or 34, 35 weeks. In uncomplicated cases, if the patient is willing, we can give a trial and
yes,
after
so that is
informed
what is the RCOG guidelines, that suppose if you have a breech presentation at around 36 weeks, because that is the time when we say the presenting part should get fixed. So if it is not fixed, then that is a time where you have to explain to the patient whether she wants to go for planned vaginal delivery and whether she is willing for the external cephalic version. So that is what is the decision at 36 weeks. Now, if suppose she is not willing, that is she declines, or there is a failed external cephalic version, still you should give them an informed choice for the planned vaginal delivery or a planned cesarean section. That is what the RCOG guideline says. Okay, so and this is what is the Zattuccini-Andrews score, where these are the parameters: the parity, gestational age, the approximate fetal weight in pounds, previous breech delivery, dilatation, station of the presenting part. So that is how you have to score this, and considering the every parameter. And if it is favorable, if the score is 0 to 4, then it is cesarean delivery. If it is more than 4, definitely you can try for vaginal breech delivery. Of course, you have to take an informed written consent for cesarean section anytime you feel that yes, there can be a problem. So in fact, that is how you have to go for the breech delivery. So yes, anybody wants to add anything?
Yes,
one thing.
Please. Please go ahead.
I would like to add that one thing is that they've written more than nearly 3.5 kg. But according to me, more than 3 kgs, the baby weight is more than 3 kgs, then
Yes,
I would not risk it.
You are
because
right,
then it's
Renuka.
difficult.
These are RCOG guidelines and these are recommendations which are Western recommendations. See, even if you see the definition of macrosomia, they say more than 4 kg. I'm sure we all follow more than 3.5 kg. Okay, so there is definitely a difference in the Western and Indian standards. So we have to modify our guidelines as per Indian standards. So you're right. So let us go ahead. Yes, Dr. Tushar. Yes,
Yes,
please.
ma'am. Regarding this case, we first explain the relatives and patient about the condition of the patient. Though she want vaginal delivery or cesarean section. Most of the time, patients say, "Doctor, तुम्हाला जे योग्य वाटते ते करा."
Correct.
In that case, I think we should go for the cesarean section in full dilate case also,
Yes.
because if the something happens to the baby during delivery or after coming head,
Right.
if stuck down, baby get in distress, then
Right.
patient can sue that आम्ही तर डॉक्टरांना सांगितलं होतं की तुम्हाला
Yes.
जे योग्य
Perfect.
वाटतं डॉक्टर
Perfect.
So
That is what
that-
I wanted to convey the message to Renuka also when she started discussing that, you say that yes, because she is fully dilated and she has had a previous normal delivery. Yes, we are trying our best to, to deliver her by the time. But if at all you feel that, there can be difficulties that needs to be explained to the patient and relatives, and that is why we suggest you to go for cesarean section. Maybe by the time you are planning everything, you are discussing with the patient and relatives and you are taking over consent, she may deliver not only assisted, but she may just, deliver spontaneously. So spontaneous breech delivery is also possible, and that will be merry for everybody. Okay. But then you have to go strategically, explain everything and take an informed written consent, what is called as informed choice to the patient. You explain them everything and then you help them making the decision. So I think that's the best strategy to follow.
Yes.
So we go ahead with the third case now. We have this 34-year-old second gravida. She has gestational diabetes. She comes to you in labor at 37 weeks. Vitals are normal. When you examine, she will find that 36 weeks size, cephalic presentation, heart, head 3/5 palpable, fetal heart is good. Cervix only 2 centimeter because she is second gravida. She progresses very fast and after 6 hours she delivers vaginally normally. So after 20, no, not deliver, she progresses very nicely. Cervix is fully dilated, fully effaced, and vertex is as perineum. But after 20 minutes of full dilatation, the head is seen, it's getting delivered, but the shoulders are struck. So what is this, Dr. Deepa, and how would you manage this condition? Dr. Deepa, please unmute yourself. Please unmute yourself. Dr. Deepa, please unmute. Unmute. No, unmute. Click on the mic icon. Can you all hear me?
Yes, ma'am.
Yes,
So,
yes, we
yeah,
can hear
Yes.
you.
please unmute. Dr. Deepa, please unmute. Click on the mic icon.
Can't hear you.
Hello? Renuka, can you hear me?
Yeah, I can hear you. I'm trying to
Yeah,
tell
but
her that.
she's not unmuting herself. She's speaking
Yes.
something. Please unmute. Saiti, can you help her? I think asked to unmute. I can send a prompt, but she's not asked to unmute. Unmute yourself. No. Pratibha, Dr. Madan, can you call her?
Dr. Deepak, can you remove your Bluetooth? You directly talk on without Bluetooth.
हेच mic वर mute दाखवत आहे ना?
Without Bluetooth, please.
Mute. Hey, mute. But she
Something
can
is
hear
wrong.
you. And now
I
you
think.
ask her to unmute. Now you ask her to unmute.
Unmute कर, unmute. आवाज येत नाहीये.
हाँ. Unmute करा, unmute. त्याचे माईकचा आयकॉन आहे ना, माईक आयकॉन. You can see here. माईक त्याच्यावर क्लिक करा, रेड कलर माईक आयकॉन. अरे
किंवा
Madan,
ब्लूटूथ
she's
ऑफ
listening
करून
to
टाका.
you.
ब्लूटूथ ऑफ करून टाका मोबाईलवरून.
नाही ते अनम्यूटच नाही झालंय. Okay, so this is the scenario. What is your diagnosis? She has to unmute herself. Kasar?
Person shared.
Can anybody call her?
Sahiti, speaker permission आहे ना?
Probably.
Is there speaker permission access given to her?
No, she's there in the panel. We can see her. She's not unmuting. फक्त ते unmute करायला सांगा.
काय प्रॉब्लेम आहे?
Unmute करायला सांगा. Unmute.
आपण ज्या व्यक्तीशी बोलत आहात त्यांनी
Okay. So can we discuss by the time? We can start, Dr. Sriraj.
Yes, ma'am. The
Yeah.
head is out.
Yeah.
This might be she's a diabetic patient. This
What is
diabetic
the
patient has
situation? Head is stuck
this is
there, not
this is
coming up.
shoulder diagnosed as a shoulder dystocia. Head is
Okay.
out and showing the turtle sign, which
Mhm.
indicate a shoulder is stuck at
Right.
in the pelvis.
Right. So how will you go?
So in a shoulder dystocia, we have to manage this patient as an obstetric emergency. In this, the morbidity and mortality of the baby is very high. So we
Okay.
have to go with stepwise procedures.
Right.
So first of all, what we can do is ask one assistance to give a suprapubic pressure so
Right.
that the anterior shoulder gets dislodged and baby can be delivered. If it is
Okay.
not possible with that thing, we have to move to the next steps. So we can take maximum 60 seconds or 30 to 60 seconds for each steps.
Okay.
After that, we can do this wood screw method. In that, the baby has to be rotated with the help of two hands, and then if get rotated and the shoulder dislodged, we can deliver by that. If
Right.
it doesn't
What is the
deliver by
most
that,
important step you feel in this? Whether it is the hyperflex leg, what is called Mac Robert?
that Mac robots.
Mac robots
First of all,
manual.
that Mac robot, most of the patient delivers with that Mac robot position and the suprapubic pressure.
Yes.
So that Mac
It
robot
is said
position
that
is a
almost 80 to
hyperflex
90% of these women deliver with
delivered by.
Mac Roberts, right?
So
So
hyper extension of this, the patient has to give instruction to the hyperflex of the both the legs towards the
right.
abdomen, so that the angle between this pelvis it is increased by slightly by 1 centimeter, and that is sufficient to dislodge the shoulder.
Okay. Okay. So the birth passage straightens, the angle is
Increases
more,
standard.
even the epidiameter increases. That is so
Increases.
hyperflexion is one step, that is Mac Roberts, and suprapubic pressure. Now you tell me which side she should give the suprapubic pressure.
So where the fetal heart sounds are heard, that is on the back side of the baby.
Right. That means it is on, see, head, you can see head, you cannot see the back. So on the side of the
FHS.
occiput, right?
Occiput,
On the side of the occiput. Now, what is the mechanism here? By pushing the, giving suprapubic pressure, what do we achieve here? See, you can see in the picture.
We abduct the shoulder. We abduct the shoulder and decrease the push the baby in the oblique diameter.
Yes.
By abducting
the
diameter is
shoulder.
reduce the bis
diameter
acromial diameter.
Yes.
The bis acromial diameter. Okay. You're pushing the shoulder towards the chest. That means you're compressing it and reducing the bis acromial diameter. Okay. So that is how both these procedure together, in fact, I would say Mac Roberts. You can see that hyperflex thighs on the abdomen and then suprapubic pressure simultaneously. That should help to deliver. So almost 90% of these women, they deliver like this, correct? So, so not to become panic, keep cool, but do all the maneuvers systematically one by one. Okay, so these two together done percentage. If not, then what?
Delivery of posterior
Yes,
shoulder.
Dr. Tushar, you want to say something?
Yes, ma'am. Then second
Okay, and
maneuver
what is
must be
this
the
good sculpture?
that is
Yes.
the internal rotation maneuvers. We have to give anesthesia for these maneuvers actually.
Okay.
Internal rotation maneuvers.
Okay.
For that, in this maneuver, we rotate the posterior shoulder in 180 degrees and 180 degree.
Actually, there's
And
no
make it
need for
anterior.
anesthesia, Dr. Tushar. There's no need for anesthesia. Whatever you are already trying to manipulate, like this. So you just in the same situation, you half circle, you have to turn the baby upside down. The anterior becomes, because posterior shoulder is already at a lower level, your anterior shoulder as posterior, so that anterior comes down and you deliver the baby.
Yes.
Okay. And if your message for this case, what is the time you should wait for? You can give how much time for this baby to deliver? Yes, Renuka.
Here we have to put the stop clock, and actually we have only 3 to 4 minutes actually before we can deliver, na? So that is a very short time.
Perfect.
So we have to be
yes.
the time,
so your eyes should always
has
be on
to
the clock, as you said. Yes. So it is not you do this many or wait for some time. Nothing. In continuation, you have to do this, and of course monitor everything and see that the baby is delivered within 3 to 4 minutes max. Okay. So should we go ahead with the next case, or should we stop?
No.
Yes. We go ahead with the next case now. Dr. Preeti, this is a case for you. Yeah. So primary gravida, 39 weeks pregnancy with spontaneous labor. I think this is only for progress of labor. So rather than this is an old partogram. I would ask you, this is a situation. She's having uterine contractions 20 seconds every 5 minutes, said 3/5 palpable, fetal heart 140, cervix 2 centimeters, 75% effects. How do you monitor the progress of this patient in labor? So I would ask you, according to the
modern
partogram, how do you monitor
yeah.
So, WHO labor care? Yes.
This may be latent phase of labor, and one should not, in fact, intervene much in this latent phase. Now, the guidelines also have, from the old, they used to say up till 3 centimeters only, it is a latent stage, and then the active phase starts. But nowadays, they say up to 4 to 6 centimeters, it may be a latent phase, not necessarily up to 3 centimeters.
So in fact, the first message is that you are not supposed to plot a partogram for this patient at this stage, correct? 2 centimeter, it's only.
And anyway, partograms nowadays, they say digital partographs and lots of apps are also available. So if you want, that is better, because this is quite cumbersome. You need a trained personnel to plot. The resources may also not be available, and most of the time it is usually a retrospective way that people are plotting. So that doesn't much help.
No, but then we are supposed to teach them, no?
Yeah.
So we are
digital apps are available, so
yes.
that shows that the time is marked, in fact, in that. So you just can't go retrospectively in that. And it is more handy also, and the alert line and action lines, they are automatically, there are alarms also set. So it's more for the rural settings and this. And actually, partograph gives us a one-page view of everything is there plotted, blood pressure, the time of admission, everything is there. So especially in where the workload is much more.
Condition.
Yeah. Maternal condition, gravity, registration number, blood pressure, everything is there. Madam, your voice is breaking. Can't hear you.
Hello.
Now I can hear, ma'am.
Yes. So what is the advantage of partogram? Only that, whether it's a e-partogram or an actual physical partogram.
No, of course it is a document.
What is advantage?
Document also, and every time you don't have to repeat the same thing, especially in multidisciplinary hospitals where there is shifts and the handovers are there. Everything is written, and alert and action lines are also there. So if the progress is slow, we can be alerted and take some action. Documentation is there mainly, and in these days of medical legal, lots of cases are there, so we can tell that it has been properly monitored. I can't hear you, madam.
We can hear you.
Acha. Okay.
We can hear you, yeah.
So partogram is in one this page only you can get everything about the patient. And especially if you want the another gynecologist is going to come or the staff handover is there, then everything is at one glance, they can take and understand about it. The alert and action lines are also plotted, so that is also giving us an idea whether it's a protracted dilatation or the descent is secondary arrest of descent or dilatation is there. That also is an idea
Yes.
given.
So, not only the maternal conditions, the progress of labor, the fetal condition, the characteristic of liquor, and of course the station, as we already said that, and the care for the baby also is included now in the newer labor care guide. So, do we have Dr. Lakshmikant? Has he joined? No, no. So, I think this will be the last case now. Second gravida, previous scissors. A quick case. She comes to cesarean section was done for fetal distress. She presents to you in labor, contractions 2 to 3 contractions in the last 10 minutes and lasting for 30 to 40 seconds. There is no scar tenderness. Cervix is 6 centimeter, fully effaced vertex at station 0. Full dilatation, at full dilatation, there is severe bradycardia suddenly. So when the vertex is at +1, there is fresh bleeding. When you catheterize the bladder, you find hematuria. So what is your diagnosis, Dr. Shiraj?
Ma'am, when patient has came, initially she was 6 centimeter, fully effaced, and station was 0. This patient might be counseled regarding the trial of labor after cesarean section. She
Right.
might be agreed for this. At that time only, we need to counsel patient as well as relative regarding the positive and negative things. Like patient might be all the risk factors associated with trial of labor, like there is can be a risk of scar descent, there can be a risk of uterine rupture. That
Right.
thing has to be told before the trial of labor,
Right.
and the chances of rupture or the things which has to be told to the patients. So there are very less likely that there is the uterus will rupture, but if patient is willing, then we can go further. So
Yeah.
patient
So
has
for this
progressed to full
patient, what is
dilated.
the diagnosis?
She has full dilated. Now there is the contraction have stopped and there is bleeding, which is increased, and after bladder catheterization, there is also bleeding. So this is a typical sign of uterine rupture.
Correct.
So this is an obstetric
Now,
emergency.
only one question on this case. Would you like to
Sorry.
deliver her vaginally at this point, or would you like to take her
Um,
for a cesarean section laparotomy and go ahead?
Immediate exploratory laparotomy, I will be prefer,
Yes.
as station is very high. That is station is +1. If it
Plus
has been patient +2, 3, we would have tried for instrumental delivery, vacuum
and
or
then go for
forceps,
laparotomy.
then laparotomy. But station is very high. Better to go for direct exploratory laparotomy and SOS if required, hysterectomy.
Right. So first and foremost, you have to think whether, you have to decide which patients can be given the trial of labor after cesarean section, that is TOLEC, and which patients should not be given. So is there any specific criteria for this?
Um, exact criteria we can't tell, but we have to assess for the risk factors.
Yeah, and the
Whether
clinical
patient has
criteria, I would say, whether she has conceived within first 1 year, whether she has multi-fetal
that
pregnancy,
is
whether she has large size
yes,
baby, So all these risks needs to be
risk
taken
factors.
into consideration, and also the scar thickness especially, which is very, very important, and of course the scar tenderness, which you can judge clinically. So all these factors actually should be taken into consideration. So with this, we would just conclude the discussion, friends. Intelligent anticipation, skilled supervision, prompt detection, and effective institution of therapy can prevent the disastrous consequences, and of course not to forget communication and documentation. So with this, I would like to thank all the panelists who have contributed so much to this discussion, and I would like to thank all the president and secretaries of Pune, Baramati, and Ahilyanagar or Ahmednagar societies. And I just take this opportunity. I can see Dr. Josna, my dear friend, and of course I will invite you for one comment. I just complete my appeal that I humbly seek all of your blessings and best wishes. And of course, I request your vote and wholehearted support for my candidature as FOPSI Vice President for the upcoming elections. Thank you so much. And with this, I invite our expert for the panel, Dr. Jyotsna Dole, to make some comments. Over to you, Jyotsna.
Yes, thank you, dear Sneha. First of all, I would like to congratulate you for such an excellent panel you have taken and this webinar also. Very well you have arranged.
Thank you,
And
Jyotsna.
congratulations to all the panelists who have given their contribution very well. The only thing which I would like to say in this webinar is, in this era of medical legal problems, the discussion, the maneuvers, the procedure, as an obstetrician, we always do.
Right.
But the most important thing is talk with the patient. Even if you are busy in delivering such patient, if shoulder dystocia is going on or the patient is bleeding, ask someone from your staff or some assistant doctor or someone to call the relatives inside and show them what is the problem, what problem is going on actually. And if you are operating such high risk patient, like if it is already diagnosed like placenta accreta or percreta or anything, and if you are taking proper consent and explanation and talking with all relatives is very, very important nowadays. We all do our job as an obstetrician completely, everything we do it, but we are always lagging in such things. So that care should be taken. That's all my contribution is.
Thank you.
Thank you so much. And I will request all the society members to vote for Dr. Sneha. She is really contesting and taking lot of efforts, and she is from small society. So everyone should vote her and help her. Thank you so much and all the best, dear Sneha.
Thank you so much, my dear. Thank you so much. Thank you. Thank you, everybody. And I would like to thank Dr. Madan Kamre and Dr. Pratibha Baldua from Solapur, for taking all the pains for me and organizing this webinar and bringing all of you together. Thank you so much. Thank you.
Thank you, everyone. Thank you,
ma'am.
Dr.
Thank you,
Madan.
ma'am.
Thank you, madam.
मदनला जरा जास्ती मला फॉलो घ्यायला लागला, पण मुलीची एंगेजमेंट परवा आणि प्रॉब्लेम. My father is admitted in ICU.
I know,
That's why
I know.
all
So
the
nice
things are
of
going
you
on.
to join, with
Okay.
all these commitments. Thank you, Jyotsna. Thank you so much.
Thank you, Sneha ma'am. Thank you once again, all the faculties who have accepted our invitation and joined today to make it a wonderful program.
Thank you. Thank you. Dr. Shiraj,
Thank you.
You belong to Pune proper?
I am proper from Sholapur, but after PG, I settled here in Divapati, in Pune.
We had our friend Dr. Katak Dond. I don't know whether you know whether he's the same. You have anybody relative as gynecologist?
So no, ma'am. I personally don't know, but my parents might be knowing, but I don't.
Okay, great. Thank you so much. Thank you, everybody.
Okay.
Please
Thank you.
do
Thank you,
vote
ma'am.
and support me.
Yes, sure, ma'am.
Definitely,
Sure.
ma'am. Definitely, ma'am.
Thank you so much. Doctor, I think we could not hear her, no, but she could not unmute herself, huh? Deepa, Dr. Deepa. Thank you so much. We missed your inputs, So
She tried so many times, but unable to unmute. Don't know why. From mobile also, and laptop also.
For that. Sorry, we missed your contribution. Anyways, chalo, bye-bye.
Thank you very much, Sneha madam.
Thank you, ma'am.
It was a very good and informative webinar, and we wishing you all the best, and we hope you get all the votes for the vice
Please do help
president.
me
Yes,
from all
yes.
your society.
Sure, sure.
Thank you, Doctor. Thank you, Doctor.
Thank you very much. Yeah.
Thank you. Thank you so much. Thank you. Bye-bye. Bye.
Bye.
Good night.
Thank you, ma'am. Bye.
Bye.